So good afternoon, everyone. Can you hear me okay? It's 12:02. I think we can get started. Um, so I'm hoping that you guys can hear me okay. So, so I'm going to talk about point of care ultrasound approach to respiratory failure. So I don't have any specific disclosure related to that. And then my objective is I'm going to have a brief outline of evidence of POCUS at bedside practice, and then overview of lung ultrasound and then DVT, and then how we can algorithmically approach to respiratory failure using POCUS and at our bedside. And then we're just going to talk about how we can incorporate it, and also future direction. So, so we probably would think, why do we need an ultrasound? I got a stethoscope, and I have an excellent bedside skill, and I'm able to read the radiography. And why just need a ultrasound to help me out? So I'm just going to start with the case, and then we're going to come back to that case at the end as well. So basically, is a 74-year-old male with a history of shortness of breath, comes in with shortness of breath and cough and chest pain, and he also feeling warm. And fast medical history, coronary artery disease, peripheral arterial disease, and he is current smoker. He's not formally diagnosed with the COPD or any of those, and not on any puffers outpatient. His temp was 36.8, heart rate 105, blood pressure 103/55, and respiratory is 28. And his SPO is 88 on room air, and D-dimer as part of the workup was like 1,000. And I'm sure that we all see these cases, every day. Thinking about what's going to be the probable diagnosis and everything. So in the meantime, and then we get an X-ray, and this looks like this, and in some portable X-rays, and then you see a radiology reads, there's persistent some densities and heart size normal, pulmonary vascular just normal limit, no evidence of pneumothorax, but given the technique, neither can be excluded. So with this X-ray, so we're still confused whether it's atelectasis in the base, or it's an edema or effusion on the right lung, or is there any consolidation? So still, X-ray is not giving us the clear information that what's the next step. It's better to do, and most of the time, I think we end up doing, treating pneumonia, maybe diuresis, and then also and antibiotics, or maybe this patient has smoking history and in liver wheezing on exam, we just end up with treating a COPD exacerbation. So we just have this conversation in our mind all the time, right? So just move this. So what are the evidence that ultrasound in the studies that I quoted here, and many traumatic studies, and ultrasound found as most sensitive than radiography for detecting pneumothorax, and very sensitive and specificity too for many other causes that we think that is reason for his respiratory failure. I'm going to go over there in the next slide. So if you looked at these, the studies and diagnosis accuracy over pneumonia, edema, or embolism, contusion, pneumothorax, pleural effusion, overall accuracy, looking at here, sensitivity is around 95, specificity around 94, which is remarkable numbers that will help as a clinician at bedside to differentiate the common causes that we encounter for respiratory failure every day. But in the meantime, it's also very cheap, meaning you don't need to get radiation to patients, and It's available at your bedside if you have an access to it. And also we also questioned that how's the learning curve, even if I start doing that, and what is my learning curve? Do I need 100 ultrasound to be more proficient? But the study's proven that 10 to 20, it's pretty good, at least to rule out, certain major causes of our respiratory failure. And it's bedside by clinician, right? So I think you have your clinical judgment from your history and examination and some other data that you collected. And then if you do an ultrasound by yourself, and you'll be able to come to a better conclusion of what's going on with your patient at that time. It's far better than the radiologist reporting the chest X-ray, because he's probably do not have much information to help. So I think these are very beneficial. Why we wanted an ultrasound. So I'm just going to briefly talk about I did talk about some evidence why we need an ultrasound is a great tool for us. And then, and we're going to go over a few, some scanning protocol and, some normal, findings to recap your knowledge. I'm sure that many of you have some ultrasound experience and knowledge. So we're just going to briefly talk about that. And then after that, I'm going to talk about how we can approach to the evidence, to what you learn and in your clinical practice. So basically, if you think about this 8 quadrants, especially in that anterior, what you basically need your right and left upper, and then just in 4 and 8 is like mostly a little bit on the lateral and lower is plaques. So these are the 4 things that at least you need to do in a quick scan, and will give you most of the information that you need to come up with your diagnosis. So when you think about probe selection, there are 3 different probes. One is linear or curvilinear, and then phase array. Linear, you also might call a vascular probe, has a high frequency. That means your depth of penetration is low. It's nice to have that to looking at your pleura very closely. And then phase array, or people call it cardiac probe, is a low frequency 1 to 5 and can go depth up to 35. And most of the time we use linear probe to look at the pleura if you're not able to find on phase array, or if you're concerned for pneumothorax, and I'll use a linear, and otherwise a phase array would be enough. So let's talk about some healthy lung bases. So here the image actually shows here is the lung sliding. So I'm going to just orient you. This is your chest wall, and that's the patient head, and this is a patient's feet, and these are the 2 ribs. And then you're looking at here, you can see the nice lung sliding, and this is using a high frequency linear. But feel free to stop me if you have any questions in between. So that's the pleural line. So here you can clearly see even better here, the same chest wall, patient head, and these are the ribs, and you can clearly see the pleural line just sliding nicely. So if you see that, so you know that is a nice pleural sliding. So, and I just wanted to focus on right here, that's the pleural line, this is a rib. And what you see here, it's a lung pulse. That means it's sliding, and then you can see the heart pulse is just moving, like, just curvy. So that's a lung pulse. If you see a lung pulse, that means that you are, there's no pneumothorax because your waves was conducted through. So if it's lung pulse, that excludes the pneumothorax. So I just wanted to show you the comparison. On the left side is the lung sliding right here, but here you can see that there's no lung sliding. Sometime in real clinical practice it might be tough, but just to keep your eye, in practice, so you can see the comparison. On the left side is the clear lung sliding, and then right, there's no lung sliding. So, and also I wanted to focus on the pleural line right here, and there was a small, white passage just coming perpendicular that it just in irregular and rising, that is not a B line, it's called just a Z line, is a normal artifact. So I wanted to make sure that you understand that it's not confusing with the B line, which I'm going to show next. So this is not a B line, this is just a normal artifact. So, and then other artifact that we actually use as a tool, because the lung is the air, if it's normal, then ultrasound does not conduct, nicely. So if you do an ultrasound beam, then it's called a reverberation artifact. It goes back and forth between the ultrasound and your probes. That creates a lines. It looks like we see a line, which is an artifact, is not a true findings, but it's an artifact from reverberation, that's what we call is an A line. So it's like plural line is right here, it's parallel lines in the same distance, and that's called A line. That A line is just normal findings, meaning there's an air there. So, but in the meantime, the M mode, it's a motion mode. It's a great tool if you doubt that you're not you're not sure about the lung sliding and you're concerned that it might be pneumothorax or not or something like that. Then M mode is a great tool. The 2D, just hit the M mode and it will give you an accurate measurement in the right on the spot. Because if you think about M mode, is like a you're taking a picture when moving, like if you're watching in a sports or anything, and if you're taking a picture that you have a high frame rate of camera needed, so then it's captured clearly. So similar to that, it's M mode is a great tool to find appropriate lung sliding, for example. So here is a lung sliding, and that's a plural line in and then if I put a M mode through the lung sliding, and then what you get is like this image right here. So I'm going to show up what this image look like in the next slide. So basically it shows a seashore sign, exactly look like this. Is a border right here, and the sand is here in the below. What it tells us is an air-filled alveolar with respiration and reverberation sound of the air bubble. So if you see this in the M mode, that means that's lung sliding. There's no pneumothorax at that point of the in area of the ultrasound that you're doing. So it's called seashore sign. So let's talk about pathology. So we talk about lung sliding and lung pulse and A line, and using an M mode to confirm if you're in doubt, to confirm the lung sliding. So pathology is easy to see most of the ultrasound, because most of the artifacts that we use for normal finding, but ultrasound, if you have a pathology, you're able to see it clearly. So let's talk about acute interstitial syndrome, that we talk about everything. So here, the first thing I want to talk about is a B line. So again, the same principle, that is the chest wall, head, and the legs. So you can see the plural line right here, and then sliding, and then hyperechoic lines rising from the plural line goes perpendicular and all the way at the end of your ultrasound, and that's consistent with the B line. And so here they use a high frequency linear probe, but you can use a phase array to see. But most of the time, if you see a B line, if it's more diffusion, you may not going to see the A line. So this is also how it's caused is because of the reverberation, or like from the pleural fluids and the interstitial septum. It's actually vibrating. That's why the images look like this. So there is a description or severity that you can actually talk about. So if it's, if you see 1 or 2 B lines, it's probably, it's not very significant. So no B line or few less than 3, that considers negative. The mile mean at least 3 you see in a one spot that when you scan, right here, and it's not coalescent, and then it comes and goes like intermittent. That's a mild. If it's moderate, so you see a many right here, and then is partially, you know, coalesced or discrete, and is persistent throughout your image. So that's moderate. And if it's severe, you can see it's just coalescence and completely, and then that's a very severe B-line. So let's talk about this. And then there's a different varieties, and sometimes, you know, the B-lines are looks different in certain other disease. So if you looked at here, if you focus on right here, you can see that this is a pleural line, but the B lines are sometimes it's subpleural, is not arising from that the pleura, and also the around the pleural line is not smooth. So it's right here, you can see it's not smooth, and your B lines are rising some subpleural. Which is actually a common findings in ARDS than if you see sometimes in pneumonia. So I'm just going to show up the comparison B line. So here is your usual B line, like from pulmonary edema and congestion, but here you can see the difference of the pleura and subpleural consolidation, or and then and with this rising the B line from there. So that is mostly you know, subpleural and irregular and red appearance is most likely related to pneumonia and ARDS. So in the real B lines, in the edema, usually diffuse, confluent, and very smooth. So let's talk about consolidation. So if in that image, and it shows that as like a hepatization, you can see this is a consolidated lungs. That's a pleural line, some B line right there, and in the black homogeneous, and then white some hypoechoic area. And also, if you looked at closely right here, there is the mucus or some particles are moving with the respiration, which is similar to air bronchogram on the CT scan, or actually mostly in CT scan. If you see an air bronchogram, then you would think that is most likely a pneumonia. So if you see a dynamic, this is called dynamic air bronchogram. So that is consistent with the pneumonia. So, but if you don't see the dynamic air bronchogram just in lungs, it could be it could be pneumonia or atelectasis or consolidation, or even mass, lung mass look like this without dynamic air bronchogram. But it can prevent lung sliding if it's really a lung consolidation and a collapse. You may not see the lung sliding. Doesn't mean that you have pneumothorax. So, and I just wanted to give you a clue then. So in small, just an orientation. So this is on the left side. So this is the spleen. You see the diaphragm here, and then the below, and you see some structure right there. And you might confuse with it. There might be a consolidation right there, but it's actually not. So let me explain why it's not a consolidation. It's actually a mirror image artifact. Why is that? Because if you're like a diaphragm, and if you're consolidation, if you penetrate, most of the time you'll see a spine sign, because if you see a spine sign above that line, then that's a consolidation or other thing. So let me explain in the next image. So this is a spleen, and this is your diaphragm, and then it's actually the artifact. It's called just a rear mirror. It's just a mirror image. That's why it's confused. And how do you differentiate in here that you can see this is the real consolidation, and you can see what I'm talking about, the spine sign. Why spine sign is because usually it's air, then ultrasound wave was conducted until the spine, then you won't see the spine if it's a normal lung. So if there is a consolidation or effusion or any other pathology, then it's the consolidation fluid is easy, ultrasound conduct easily on those medium, so that you will see the spine. Here, you actually see spine sign until the diaphragm, and then it's not seeing anything. So that's a sign of like the mirror image artifact. So this is actually the mirror image artifact on the left. On the right the liver and diaphragm. This is a consolidation or collapsed lungs, and then effusion around it. So, and then next, so we talk about consolidation and then the air. So here, so you can see that's the pleural line. This might be an A line, and then you can see the previous images that showed a nice sliding. Then you don't see much lung sliding right here. And if you doubt, then if you put an M mode through that, and this is what you're going to see, which is called barcode sign or Stratigrapher sign, which is consistent with pneumothorax. So this on the left side seashore, which is a normal lung sliding. On the right side is a barcode sign, which is, you can clearly see it looks like a barcode. That's the point that it's no lung sliding. So what are some of the possible causes of absence of lung sliding? It's not only the pneumothorax, the patient's apnea, probably not going to see in the regular floor, but if your main stem intubation and left side, if you do it an ultrasound, you may not going to see the lung sliding. If there's an obstruction, or if the patient had a pleural disease, perhaps bats and chemical or whatever, then you might not going to see the lung sliding. In severe COPD with the blebs, and large blobs, and you might not going to see the lung sliding. And sometimes you're in severe ARDS with the pneumonia, and you may not going to see the lung sliding. So clearly, and just want to talk about lung point. So this part, it's a Stratigrapher sign, it's a barcode. So if you hit if you put a probes in that position, you can see that here clearly it's sliding, but it's in this part is not moving. So that's called a lung point. If you see a lung point that's pathognomonic, that means that you got a diagnosis of pneumothorax. So here is an example of how it looks in our CT scan. So if you do that in that point, you will see a lung sliding. If you do it here, you may not going to see a lung sliding. So, and then here, if you put a probe in there, then you're going to see a lung point. So basically, if you see a lung sliding, yes, then there's no pneumothorax in that particular part. And then if you see a B line again, that's conducting through the air through the entire lungs, that means that you don't have a pneumothorax. And the lung pulse, again, I told you earlier, that if the lung pulse is in waveform is conducted through the lungs to the pleural surface, that means there's no pneumothorax. And again, if you see a lung point, then that's confirmed that you are pneumothorax. Then if you don't see a lung point, you need additional testing for the confirmation. But if you find the lung point, just get more information and to confirm your diagnosis. So what do you see here in the X-rays of your patient comes in, and then it's shown as a breath, and you have a chest X-ray like this, and it might confuse with pneumothorax. But looking at the curvature here, it's more concave than convex. It's probably look large billa. So if you do a CT scan, and this is what this looks like, so make sure that especially in those kind of patient, they need a better imaging for diagnosis. So a couple of other things might confuse with the lung point. So here, if you can see that is the lung sliding comes and goes, and you might confuse with whether this is a lung point or not. But it's actually, if you're looking at the position of the probe right here on the left corner, it's actually the diaphragm reflection, but not a lung point. So just making sure if you're in the posterior lower part of the lungs, make sure that is not, interpreting as a lung point. This is a diaphragm reflection. And it's similar to if you're in the heart, it's called heart point. It's a similar that comes and goes, and you might confuse with the lung point, but it's a heart point, not a lung point. So again, we talk about the pleural air, and how do you diagnose with the lung sliding and pneumothorax, but we're going to move to the pleural effusion. So in terms of pleural effusion, usually you're gonna, looking at, make sure that you're identifying the three main structures. So usually I go down to looking at this is the kidneys, and then go up a little bit, and then you'll see a right side is the liver, or left side is the spleen, and identify the diaphragm right here, the hypoechoic, the white area. And then if you move further up, and then you will see whatever in between, that's going to be your area of effusion. So, and then you will see a spine sign right here, but that's, it's actually below your diaphragm. So that's a normal finding. So here is a good example that, I said you need to identify that's your chest wall, and this is your diaphragm, this is your spleen or liver, and here is your lungs, and this hyperechoic black is your effusion. So that to make sure that you are above the diaphragm. So sometimes if it's patient with liver cirrhosis, and if you put a probe, you might see an hyperechoic and fluids, and that might be an ascites, just to make sure that you're identified the diaphragm, and then chest wall and the lungs. So those are the three things that you need to make sure you identify, to confirm that it's the pleural fluid, and that's the spine sign. You can see that it's above the diaphragm now. You can see the spine sign because it's a consolidation or atelectasis and with the effusion. So that's why you're seeing this spine sign. If you're not seeing a spine sign, maybe it's a mirror image artifact. So here is the same, just, pans into the ultrasound on the right, left side, just looking at the three images, the diaphragm and chest wall and the lungs, and you'll find the pleural effusion. So we talk about, what's the evidence of ultrasound, it's helpful. And we talk about what's the normal finding that you need to know, and some of the abnormal finding that need findings of pathology. So, and then we're going to put all these together, how we approach to the diagnosis. It's called the Blue Protocol. It's published in Chest in 2008, a while ago, and it's proved that it's improved our diagnosis accuracy and treatment and early discharge and so on. So basically what you're going to do, so in here, the number one, you can do an ultrasound of the lungs, and then if your ultrasound lung shows lung sliding and then a profile, then you just go to the legs to look at the DVT real quick. And then if there's no DVT, you're going to come back to do the plaques. It's a posterior lateral, and so PLAPS, posterior lateral and alveolar and pleural syndrome. So it, literally, if you train yourself, it's going to take, few minutes, 2 to 3 minutes. So let me explain how you approach and you differentiate all these diagnoses that confuse us every day. So when you put ultrasound probes on your right side of the chest or left side of the upper chest, and you're looking at the lung sliding, that go to on the right side. So you see a lung sliding is present, and you're looking at profile. What kind of profile I see with the lung sliding? Is it A profile? Then A profile means that, it's a normal looking lungs. Then you wanted to make sure you don't have any DVT. You go back to looking at the femoral area. And I'm going to talk briefly of the DVT scan. Looking at the DVT scan, if you don't see any DVT, then you do go back to 3, which is on the posterior lateral. And if you see any consolidation effusion, then you go back. If you consolidation effusion, that if it's consistent with pneumonia. If you don't see anything with the patient with the history of asthma or COPD, and that's probably related to COPD asthma exacerbation. But if you're lung sliding and then the B profile, they'll give you mostly in diffuse. I told you about the grading, mild, moderate, severe. Depending on that, that's probably the major driver of respiratory distress or failure. It's in pulmonary edema. And if you do a lung sliding in A profile, and then you found the DVT, and then most likely it's a DVT PE, the course for the embolism, but you can confirm within CT pulmonary angiogram. But at least if the patient is unstable, I would probably treat them as a PE. And other images like looking at the heart ultrasound, the RV might help in a hemodynamically unstable patients. But that's kind of at least to give you a clue of this is probably the PE, the driver of the shortness of breath. So if you go into the left side, if your lung sliding is absent, and then you have a more B profile or C profile that I told you that with the B line is arising with subpleural and dragged appear in the pleural surface, and that's probably pneumonia and ARDS driver. And if your lung sliding absent and your lung point, then it's confirmed that you're pneumothorax. And lung sliding is absent and you don't see lung point in anywhere, that you probably need a CT scan or something like that. So it's pretty simple that the two images in the anterior chest and go to the legs and looking at the DVT, and then come back to the 3 on the posterior lateral. So 3, it's basically you're going to do a 6 parts, and if you have an access to ultrasound, it'll be easier. But I'm sure that we don't need to do for each and every patient, but the patients are confusing us and need more clarity. So what's going on with that patient? I think ultrasound is a great tool. So just briefly on an ultrasound of the legs. So I think there's a prospective study of almost 2,500 patients. The 2-point ultrasound that I'm going to talk about briefly on the next few slides. And versus the whole ultrasound by our, radiology tech and then read by radiology, it's pretty much comparable as in detecting symptomatic DVT in an outpatient. And then because of that, and then they did a study on other, and I'll talk about basically what you do is like most of you, I'm sure, into the medicine training, you have done some femoral lines and everything. You just need to find the femoral vein and just pan a little bit up and down to see an entrance of the deep femoral vein and saphenous vein. That's one spot. And then you go back to the popliteal vein, basically just bend this patient's knee and then put a probe in between the two, tendon, and you're going to see a popliteal vein. And a popliteal vein is usually on top of the artery. So pop on top, this is popliteal vein is on top of the artery. So I'll share some images afterwards. So and I think it's a 2-point screening, and with then extending into saphenous vein and common femoral vein, you don't need to move, a little bit move, you will see that, and that's pretty sensitive to finding a DVT, rather than waiting for ultrasound and for a few days, and then and waiting for readings for another day. So what they found from this EM study and some ICU studies, actually, if you looked at the EM study, they have like 100% sensitive and 99% specificity, which is great tool to find ER docs to find out and with the patient at DVT. Even with the ICU study that we know that it's it's difficult patients and mobilities and everything, they're connected to many things, but still the sensitivity and specificity it's great as a tool. And we did a lot of ultrasound DVTs, and especially with COVID time, and because of access to ultrasound. So basically what you do is like it's the right, so you can see there's the femoral artery, there's the femoral vein, that's a saphenous vein entrance right here. So if you compress, and so there's no DVT. So it's your left side, you can see the femoral artery, that's the vein, that's the femoral vein entrance. And this is the popliteal vein, so popliteal artery. So if you compress, and there's no DVT here. So the caveat of that is like you make sure that you see an artery next to the vein, and if you compress, then it's confirmed. Then if you don't see an artery next to the vein, you cannot confirm that's a vein. That's probably you're confusing something else, like lymph nodes and everything. So you must see an artery next to the vein in order to confirm. And also, like just pan a little bit up and down, just see the femoral saphenous vein entrance. And also in the popliteal vein on the back of the knee, just to span a little bit more and to see a trifurcation. So if it is normal, that means the vein collapse, the walls touch each other, that means normal. And if it's abnormal, that means they have a DVT. Your artery started collapse, but the vein is not. That means there is an abnormality, meaning the DVT. Sometimes fresh clot, it looks black and you can see anything, but if it's not collapsing, with the artery started collapsing, that means there's an acute clot. So let's do some questions. So which of the following is correct about the clip shown here? This patient definitely has pneumothorax, and lack of lung sliding doesn't rule in a pneumothorax. And I see a diffuse B line or normal lung sliding is demonstrated. So you see here's your chest wall, here's your head and legs, and these are the ribs. And this is a pleural line. And do you see any lung sliding? No, right? There's no lung sliding. But is it rule in for pneumothorax? It's not. There are many other reasons. So, but you don't see any B line here, right? So there's no lines rising from here in perpendicular. So there's no diffuse B line. So the answer is, the lack of lung sliding doesn't rule in. So you need more information about what's going on in this patient. So next question, I think it's typos, that's the second question. So spine signs maybe indicate. So what is spine sign? You can see that spine is, you see a spine here. So this is the liver or spleen, depending on the site. And that's your diaphragm. You can see our lungs here, and this is your pleural effusion. So if you see a lung sign, a spine sign above the diaphragm, that means there's something going on here, that ultrasound beam is conducted easily. So it could be pneumonia, this might be, that's even, hemothorax or effusion. So the answer is all of the above. So let's come to our case. I think I'm going real quick. So we can, talk if there are any questions. So this is the same case that we, started with, 74-year-old male with the shortness of breath and everything. So it's kind of smoker, so it's tachycardic and blood pressure kind of borderline. The respirator is 28 and hypoxia, and D-dimer is elevated. So you could see like he's feeling warm. So whether this is pneumonia or like with this, COPD with, whether it's COPD or is this tachycardia with elevated D-dimer, whether he has PE, all sort of things are possibility. So then this is what we talk about, earlier with this approach. What are you going to do? You're just going to do an ultrasound on the chest and going back to the DVT and coming back on a 3. So let's look at the images and then we'll come back here. So when we scan this patient, then we in the anterior part of the chest. So what do you see? It's both, here it's clearly an A line. So this is a pleural line right here. This is a chest wall. This is an A line. So and you see a lung sliding. Yes, I do a lung sliding, and it's an A line. So which is like an A profile with lung sliding. And what is this? This is a good, nice lung sliding. And is it a B line? It's not a B line. It's not conducting all the way up, and it's just inconsistent. It's a not defect. So again, this is the lung sliding, no B lines. So it's probably what we think is like lung sliding with A profile. So what the next step is, just do a DVT scan, and then if DVT scan present, then likely a pulmonary embolism. If a DVT scan absent, we're going to go back to the posterior lateral area. So this is a profile, and then you're going to do an ultrasound in all 4 area, right and left, and then you're seeing here, and there is no DVT, so you're completely collapsing right femoral, right popliteal, left femoral, and left popliteal. So there is no DVT. Then you went back and look at the posterior lateral aspect. And what you see here, so that's a chest wall, and that's here is your head, and this is your legs, and that's your diaphragm, and that's your liver, and you see a spine sign, and that's your lungs. And if you look at closely, you can see that dynamic air bronchogram just comes and goes. This hyperechoic area with diffusion. So then you know the diagnosis. So it's in a more clear evidence right here. So you can see the dynamic air bronchogram. So you have the diagnosis for the patient, this dynamic air bronchogram, and this patient is pneumonia with some effusion, could be a pneumonic effusion. So it's clearly that it might be tough sometime, but I think if you are finding this and you're like initially with this history and examination, you were still figuring out what an appropriate diagnosis for this patient. If you do these 3 steps, and you're most likely going to come to the conclusion that it's most likely this patient has pneumonia, you're going to favor that and treat it, focus on that rather than shooting in the dark with all 3, like steroids and antibiotics and also some Lasix. So I think it's just otherwise we'll do them. So you're, I think, now able to recognize the normal healthy lung, what's like a line, and using a B mode or normal ultrasound mode or M mode, lung sliding and A line, and recognizing common pathology like B line and lung points, and to figure out the algorithm of pneumothorax and alveolar interstitial syndrome, including and then consolidation and then effusion. And using a scanning protocol, which is very, very simple. As long as you know the protocol, it will be very simple. Use your blue protocol to figure out what the reason for this shortness of breath or respiratory failure. So I would say like a take-home points are like normally like aerated lungs are healthy. It's difficult to visualize, and you're going to see only sliding and A line. But the pathologies are like consolidation or effusion or pulmonary edema, or it's quite visible because of the AR is not conducting with the pathology is easily conduct, so you will see the pathology easily. So B-line can be a spectrum of disease. It's not just a B-line, it's pulmonary edema. So just to make sure that. And absence of lung sliding does not equal to pneumothorax. Then if you see your lung point, that's consistent. But if it's just lung sliding is not equal to pneumothorax, but to raise the possibility, just need a more in-depth scanning and or other images. So systematic approach using an ultrasound, lung ultrasound will give you an clear idea what's going on in your patients. So with that, I'm gonna stop, and feel free to ask me any questions. I think we have more than 10 minutes, 15 minutes. And I'm available. Mostly I practice at Bertrand site. I'm happy to help anyone interested in doing this. I'm sure that is an access to ultrasound might be the challenge, but I think we're not gonna use them for every patient, but it's really useful tool. And as a clinician, as a bedside, figure out exactly. I think Martin, I think your hand's raised.
Sure. Yeah, Nursham, thanks for this talk. We've been using this technology in the ICU for a few years with I think pretty good success. Can you speak to 2 points? One is having identified a pleural effusion, is there any data on success of pleural drainage? I mean, it used to be the teaching that you never let the sun set on a pleural effusion. Does this sort of now open up the opportunity for patients to get a thoracentesis or a chest drain more safely or efficiently? And then the second question is, as an administrator, how would we credential people having the skills, knowledge, and abilities to deploy this set of techniques, or is that not necessary for these things?
Yeah, those are a great question. I think, there is clear evidence that using an ultrasound, when you find an pleural effusion, using an ultrasound guided um, and thoracentesis, it's definitely more safer. It's similar to like, central line and so on. But the evidence is not, it's lacking whether you do a real time ultrasound versus the ultrasound and marking. It's not there. So you can actually ultrasound and mark the area at the time, not just in the radiologist marked and you do the procedure after a few hours. I think definitely marking at the time of positioning the patient and make sure that in the right position, and then you do the procedure at the time. Definitely in less complication pneumothorax and in others. So definitely I would do that, and then and to marking. So the second question for the credential or competency are two different things. And credential is, it's going to be depend on how our system agreed upon with an administrator, and to see, this person is able to do it safely. So what I already alluded earlier, this learning curve is very, steep, and there's only need handful of ultrasound. And if we able to have some dedicated people that are able to, review the images or like some supervision, and to give some feedback, and 10 to 20 in the range that most of their studies have proven that is a good numbers to make them, credential. uh, but definitely there are many ways that you can actually do them, and a certain way that is a simulation exercise. Once you think that is they did 10, 20, they applied for a credential, you can actually do a quick assessment with them, and as an administrator or someone dedicated to them, and can credential people to do that. But that's one thing. Competency means that they are, competent enough to do, that's different. But I think an administrator and then hospital administration can be different. So most hospital administration that I train and worked in, they do like 10 to 20, and when they apply, and you can do a quick assessment at bedside or a simulation scenario, make sure they hit all these safety protocol they use, and they're doing it safely. And this is, safe, right? For the basic ultrasound diagnosing what the problem is, it's probably safe, and you're not going to make mistake. But I think, finding some other artifact to make sure that you're not misunderstand or interpret in a different way. I hope that answer your question. So yeah, if Martin, if you have any questions or anything, that I'm happy to chat with you offline. And even for a lung ultrasound or a heart, I think you probably do that in ICU, um, and many other protocols, and some advanced technology like fluid resuscitation with Vexus and so on. So there are so many things that is, currently available as a critical care physicians.
For interest, we are collaborating with the Emerge group, who has 2 ultrasound fellows per year, to roll out Vexus primarily over the next few weeks. So if there's some people that are interested, reach out. I think we have a training session on the 27th of March, if I'm not mistaken,
Okay,
to deploy that a bit more widely.
perfect. Okay, let me see. There's a few chat. Okay, sounds good. So if you don't have any question, I think, we have a few minutes to your time for, and And feel free to grab me if you have any ultrasound, if you do it at bedside, and happy to review and help.
Thanks, Niroshan. It's a great talk. Appreciate putting it together.
Okay, thank you so much. Have a good day, guys.